Recording? Yeah, there it is. So, hello everyone, and welcome to the local session on navigating realism. Today we are going to discuss about the modular approach to evaluating wheat flour fortification. I am Dr. Prasad Bogam. I'm the research director and monitoring and evaluation director at Fortify Health, and I'm based in Pune. And today I'm joined by Mr. Akbar Ali, who is a senior monitoring and evaluation officer at Fortify Health. Uh, Today, we are thrilled to discuss about Fortify Health's intervention, about the program that is implemented at Fortify Health, and our evaluation approach for evaluating the wheat flour fortification in India, which helps us to navigate through the different complexities of evaluation and also achieve our mission effectively. So I'll be moving the slides. Yeah. So talking about the mission of Fortify Health, our mission is to enable access to micronutrient-rich wheat flour to reduce and prevent iron deficiency anemia. When we say, so in this mission, it is very clear to us that we have a very clear intervention about enabling access to the micronutrient-rich wheat flour. And also we have the outcome of reducing, or the goal of reducing and preventing iron deficiency anemia. When we talk about anemia in India, all of us know that anemia has a significant burden of disease in India. As per the latest National Family Health Survey, NFHS 5, which is all the reports are out for NFHS 5. We know that about 67% or 2 of 3 children are anemic. From children of 0 to 5 age are anemic, as well as about half of the pregnant women are anemic in India. About 52% are anemic. So that's a huge burden of diseases in India. And that's certainly not on decline as well. As compared to the previous surveys, we have seen that the prevalence of anemia has increased. So, and also the economic impact of anemia is also huge. We see that anemia impairs the cognitive and behavioral development in children and adolescents. Also, it has a negative economic impact on the workers' productivity because of its symptoms like lethargy. There could be low productivity among the workers. So every one of us know that anemia is a huge problem in India. And to combat that, we are working on wheat flour fortification. Fortification is one of the strategies to combat anemia. And if you talk about anemia, iron deficiency anemia is one of the most common type of anemia, which again, the common cause of the iron deficiency anemia is inadequate iron intake. And some of the food strategies for to combat the iron deficiency anemia is there could be diet diversification, there could be biofortification where already the crops are fortified. Then there could be fortification is one of the strategy, and also supplementation is one of the strategy. So among all these different food strategies, fortification is one of the most beneficial or most cost-effective strategies because it is cost-effective. The other strategies like supplementation or biofortification or diet diversification is they are quite expensive, whereas fortification is very cheap. It does not require any changes in the consumer's behavior. The consumers, consume the staples as they're consuming. So there is no specific education that is required, as well as the supply chain is also maintained as it is. So there is no change in the supply chain that is needed when we do a large-scale food fortification. So that is why Fortify Health chose wheat flour fortification as one of the medium to reduce and prevent iron deficiency anemia. So at Fortify Health, we facilitate the wheat flour fortification to kind of combat iron deficiency anemia, and we support the government programs and the open market programs to launch the wheat flour fortification, so that large number of population or the intervention is reached to the large number of population through the existing distribution channels. So at Fortify Health, we have a three-pronged approach. The first approach, as I mentioned, is open market approach, where we support the open market millers, wheat flour millers, to cost neutrally fortify wheat flour, or we call it chakki atta in India. So we do it cost neutrally, so that through their distribution channels we reach to the open market consumers. The second approach is the government partnerships. So we support the government departments or the government programs to mainstream the wheat flour fortification to the safety net programs. So that again, through the distribution of the safety net programs, we reach out to a large scale of population. And the third approach is the evidence generation. So that entails the monitoring and evaluation activities, so that we generate the evidence and we inform the public about the value of fortification. So this is the three-pronged approach. So if we have to focus more on the evidence generation, as the topic for today is evaluation, when we focus on the evidence generation, it basically, and as I said, it entails the monitoring and evaluation at Fortify Health. At Fortify Health, the monitoring and evaluation is a diverse team. It is comprised of the team from public health background, from food technology background, and basically what we do is we develop this monitoring and evaluation strategy, which comprises of the theory of change, the assumptions and the theory of change for different programs, identifying the indicators. Then we have the program monitoring activities, where we identify the indicators, we design the data collection tools, and then we set up the data pipeline processes, visualizations, dashboards, so that the stakeholders can monitor what is happening, the outputs, activities of the program, and also uh, yeah, they can monitor the outputs and activities of the program. Then we have a research team which understands the literature, understands the fortification landscape, literature of anemia, about fortification as well, and helps to deepen our understanding in these topics. So, and then we have an evaluation team which focuses on evaluation process and impact evaluation. And then there is a quality team which trains the open market millers and the implementers on the ground on collecting the data for monitoring and evaluation activities, and also for doing the quality assurance and quality control related activities at the mills. Certain other quality related tests, like the spot tests, which are a field based test to determine whether the added iron in the fortified wheat flour is adequate or not. Uh, that is being trained to the mill staff, and then they do the spot test and then they share it with us. And also the quality team supports in the regulatory compliance to support the as per the FSSAI guidelines, whatever the regulatory compliances are, they support in testing the fortified wheat flour for that. And as well as the internal iron testing is done to determine whether the iron levels are as per the FSSAI guidance or not, and also to troubleshoot any deviations in the iron levels. So all this is all about the M&E functions that we do at Fortify Health. And now, so these are very diverse functions that we do. But now, again, we will double click on the impact evaluation part of the M&E at Fortify Health. So before that, just want to also highlight why do we evaluate per se. So basically, everyone knows in monitoring and evaluation is one of the key aspect of monitoring and evaluation. And we do that for enhanced decision making, to basically inform the data-driven insights to the stakeholders, so that the strategic decisions can be made. Also, it is helpful to it helps in basically to shape the policies, so that the policies are grounded in evidence and measurable outcomes. Then also we have the evaluation is done also for the organizational learning. It helps us to um, uh, improve the program implementation, fosters a culture of learning, and as well as it also helps to kind of create a repository of the lessons learned and the best practices that we learn from the program implementation. It helps us to kind of manage that knowledge and share it with the stakeholders and the partners that we have. Also, evaluation also helps in improved accountability. It helps us it helps us to demonstrate our effectiveness and impact of the program to the stakeholders and the funders, and also helps us to share our knowledge with other partners as well. So that, and it also helps us to take the decision to whether the program needs to be continued, needs to be expanded, or needs to be modified or adjusted based on the learnings uh, that we have from the evaluation. So already we have talked about why the evaluations are needed in a general context, but in terms of Fortify Health, there is a lot of literature on fortification in India and outside India, but a lot of that evidence or literature uh, is not directly aligned with the context of in which the Fortify Health works, and also in the context, in the recent context of the different guidelines that the FSSAI has published. So the FSSAI guidelines, the latest guidelines are in 2018, and there are not many papers out there or not many literature out there studying the studying the evidence on the latest guidelines. And also there are a lot different iron salts for fortification. There are different types of salts like sodium iodide, ferrous fumarate, ferrous sulfate, and a lot of these public earlier literature studies, they were done with the different salts. So we at Fortify Health, we are using a specific salt at a specific dosage, which is advised by FSSAI as per the latest standards. So we don't have a lot of evidence on that, as well as understanding the impact of fortification, the context in which we work with, the states that we work with, the populations that we work with. So all of that is very important to understand in the context of Fortify Health. And also it gives a strategic input to the program design to improve the scale and the sustainability of the program. And also it helps us to generate the evidence for shaping the policies as well in the vitro fortification space. So usually there is the implementers or funders, they struggle with the dilemma that whether we go ahead with a rapid scale up of a program, or we go ahead with conducting evaluations, or we do both. Both is also one of the options. But this is always a dilemma that the implementers or funders struggle with, because the rapid scale up of program gives you a immediate result, uh, an immediate result to the beneficiaries directly. When you scale up the program, you can reach out to a large number of beneficiaries. But if you conduct an evaluation, it is more of, it gives you information about the efficiency, effectiveness of the evaluation. It takes time, but it gives information about the sustainability of the program, whether the program can be sustained, and it gives an informed decision for continuing the program as well. So this is always a dilemma, and it is like building an aeroplane while flying it. But sometimes some of the programs have that privilege, and they're fortunate to kind of manage both as well from the start, and some don't. In realistic world, we see that there are a lot of uncertainties in terms of planning evaluations. The uncertainties could be in terms of the funding. That there is the limited funding could restrain the evaluation, because conducting evaluation is a resource intensive process. And also aligning the timelines with the program implementation is also important, because there could be a lot of uncertainties where the program is already started, it is already scaled up, and then aligning the timelines as per that could be a challenge. Also, the technical capacity at the time of evaluation could be a challenge. And also there could be uncertainties in the scope, in terms of the depth and the breadth of the evaluation design itself, uh, where a lot of evaluators, they struggle with like how deep we should go into the evaluation, and what should be the breadth of evaluation, whether we include all the indicators, what population do we include, what geography do we include. So there are a lot of uncertainties in the scope as well. So these are some of the challenges that usually while planning the evaluations, we face up with. And usually it happens in a real world scenario. It happens that we have to really get on the ground very quickly, and we have to design the evaluation very quickly. If we don't have lot of inputs on these different variables, we have to really go ahead with assuming a lot of things, and that could also lead to a poor quality of evaluation. So that's how we came up with actually having a modular approach in the evaluation. So what the modular approach means is basically we are flexible in our study design, or we kind of allow some flexibility in the study design while designing the study. And also we have different levels of scales. It could range from low scale evaluation to a to a high scale evaluation components. So different kind of levels or different kind of components in the evaluation, and those could be added into it. And also the design has to be modeled in terms of that we are adaptive to the different context, different population, different timelines of the program implementation. Because a lot of times when we implement the program, we are not very sure about the program timelines, we're not sure about the population, the program might scale up very rapidly. So the evaluation design has to be adaptive and flexible enough to kind of accommodate all these changing conditions in the programs. The intervention could change itself at times. So that also the evaluation modular approach of the evaluation should consider that. And also the efficient resource utilization for sure. Like also we need to have an understanding of what these different modules will and what kind of resources will be utilized for different evaluation components and different modules. So it is basically a kind of a flexible adaptive approach to design the evaluation rather than just having a single design for evaluation. We are kind of creating if you can, like, if for an example we are just creating a kind of a different set of menu for evaluations and evaluation designs, and then we are kind of choosing and picking the different things that we want to as per the changing program needs, and as per the funding availability, as per the timelines, we could pick and choose the components that we want to. Uh, as so this is like some of the variables in the matrix that we would like to be added in the while designing the evaluation at Fortify Health. So populations could change. So these are the variables in the matrix which could change as we go ahead, as or some variables could change, some variables remain constant. Like populations could change. We might serve different populations in different geographies, in different context, so those could change and we could have a different options for the populations as well. The indicators, the those don't change. Some of the mandatory indicators, like for example, if we are measuring preventing and the reduction of iron deficiency anemia, so in that case, the indicators like hemoglobin levels or anemia indicators, like or iron levels in the blood, serum ferritin levels, those are the mandatory indicators. Those are the primary outcome indicators, so those may not change, but some of the supporting indicators might change. Like for example, some of the diversity diet diversity scores, or some of the other questionnaires on the diet, those could change based on the population, based on the context that we are working on. So we need to identify which indicators are mandatory and which indicators are supporting, and those are good to have, but may not be a primary outcome. And also coming to the study design, this is most important part in designing the evaluation. Study design is whether we need to have intervention versus control, or whether we need just have an intervention arm. Then how do we randomize it? Whether there could be an option of completely non-randomized design, or a randomization, or a quasi-experimental study also could be there. Then study arms could be how many study arms or study groups that we are including in this study. It could be a single arm study, or a single group study, or it could be a intervention control, or it could be two interventions and a control. So those arms also we need to define in this modular approach. And then also we need to, depending on the population, depending on the primary indicators and the design and the randomization and the arms, we need to then estimate the sample size based on um, estimate the sample size, and based on all these different variables, then we identify what are the different viable evaluation models that we could come up with. Ideally, this having this design would be really helpful when it is done at the initial stage of the conceptual stage of the program where the program is being designed. I think ideally a lot of this thinking needs to be done at that point in time, but really in a real world, at a lot of times we don't have the capacity, or we don't have the um, you know that is not possible at times. So but still, this modular approach helps us to kind of have a template for all the evaluation designs that we can have, and then we can make more faster decisions to start implementing the evaluation. And some of the things that we need to note about the modular structure is that, uh, like, we need to document. So all these different, so what we do in the modular structure is we define these different viable models of evaluation, and and then we and then we have a separate design for each of these models, a separate sample size for each of these models, and indicators defined for each of these models, and then we have all these many. Also, one thing we need to document is the limitations for each of these models, because that is very important. Um, uh, a simple pre-post study with a lesser sample size, with lesser indicators, as compared to a large-scale randomized controlled trial. These two designs are very different. They have their own limitations in terms of the robustness, in terms of the resource utilization, that the resources needed. So all these limitations need to be documented, so that whenever we are making those decisions, we go back to these limitations and we understand what are we trading off with. So that is one very important thing. And also, to just to be ready with the implementation, we need to create a draft budget and Gantt charts for each of these models, so that we know that what is the timeline for each to implement each of these evaluation designs, and what is the resources required to implement each of these design. So that is also important. And also, one more thing to consider is in each of these models is how we can leverage the existing monitoring data. We are collecting a lot of data through our routine data collection systems in the program monitoring approach, and which of these variables can be leveraged, and they can supplement this evaluation designs, that also could be considered. And we need to correlate them with the evaluation design and integrate them into the evaluation design. And also, these models only, they just serve as a different templates for evaluation. But as I mentioned, like, this approach is more for the flexibility and the adaptiveness. So even whenever we pick and choose one of these models, we again need to rethink of the program context, the need, the timelines, and again tweak that the template as we want to. So these were the things that I wanted to share about how we thought about evaluating the designs at Fortify Health. Uh, Now, Ali will be taking over, and actually Ali will be sharing about the evaluations design that we have actually developed or drafted at Fortify Health, and how, like, we have also used this similar modular approach, so that we can actually pick and choose based on these designs and adapt to these designs, so that whenever a need comes up for evaluation, we can actually will be more swifter and quicker in getting the implementation started. So handing it over to you, Ali. I can change the slides.
Sure. You can continue sharing slides in interest of time. Um, so hello everyone. Thank you, Prashad, for sharing about the program, about why we want to evaluate and what is the modular approach. I'll take you guys through these different studies which we have included in this modular approach. I'll be quickly sharing about the background of different studies which we have included in the protocol, and some details, not very much into the depth, but some overview of those studies, methodology and sample, etc., and analysis plan and next step. Yeah, can go to the next. So basically, we have created one study protocol in this modular approach. As mentioned by Prashad, the purpose is very much clear that the implementation of a study depends on the availability of resources, the nature of the partnership, the program we are implementing, and the feasibility and the urgency. So, and when we want to estimate our impact or effectiveness of our program, we need to have these impact evaluation studies in place. So we have created this protocol where we have different designs of different scales, and largely in our protocol we have included 4 different types of studies, and we have divided them into 2 parts. First part we can see the efficacy evaluation study, and then the second part where there are 3 different designs which we have included are for the program evaluation basically. In the efficacy evaluation, we simply want to understand the effectiveness of sodium iron EDTA, which is the salt for the Fortify data, which we are using for the fortification program. So what is the efficacy of that salt with the current doses which we use of the government of India? So that is a separate, very small scale study where we can implement this study to simply understand the effectiveness of the iron salt, basically. Another 3 studies are for the program evaluation, which can be implemented directly amongst the participants or direct beneficiaries of Fortify Health program. So within that also, we might have the resource constraint or time constraint, or the feasibility of that. Depending on that, we have created 3 different study designs which can be picked as per the feasibility. So one study which we have included is a very small scale pre-post study, which we can see just to evaluate the effectiveness of the program. Very simple. Another, we have included on medium scale. If the available resources are enough to implement, then we can have a medium scale study. It can be a quasi-experimental design, which have more of the which can establish a causal relationship by having a control group, not only a single arm study like B1 or A, but a little advanced when we go. So we can establish some relationship between the intervention and the outcomes, which we receive. The third study is a large-scale experimental design, which can be implemented to see the large-scale impact of the program. Every study in this module have their own limitations, as mentioned by Prashad. Like some would have a single arm, some would have uh, multiple arms, more than one arms of the group, the treatment and control groups. So basically, and then they would the results of those studies. How do we attribute the change to the intervention itself? Depends on the study size, the design of the study. So basically, these are 4 different studies which we have included in our protocol. The aim of those studies, I'll talk in the next slide. Shad, you can go to the next slide. So aim of the first study, study A, which we call it as an efficacy study. This is basically to understand the effectiveness of the sodium iron EDTA fortified wheat flour on the anemia rates. Basically, we have evidences with us from the fortification programs, but then those evidences, those interventions were within those interventions, the fortification was done on different doses. Like doses were very high. It was around 50-60 milligram per kg of fortified atta. But the current program which we are implementing is basically as per the FSSAI regulation, Government of India regulations, where the doses are very low, 14 to 21.25 milligram per kg. So on this, we have very less evidences, so that just to see that efficacy, we can implement this study. It is very simple, small scale study on the beneficiaries which are not direct beneficiaries of Fortify Health, but then we can have a provision of Fortify data for those beneficiaries, and then we can see the effectiveness. The B1 study, it is small scale study, as I mentioned in the previous slide. Just if the resource constraint is there, we can just simply pick this small scale study design and see the effectiveness in with one of our partnerships project, probably, where we have we can have the baseline data, and then we can introduce the intervention, and then we can see the effectiveness of that. The third study B2 and B3 are more of like experimental designs where we can see the causal relationship, where in A and B1 we are not having the control group, but the B and B2 and B3 are having a control group also, so that we can see the relationship and change and how the attribution could be made with this study designs, like the change at the end of the intervention we can see. So for that we have one medium scale, this impact evaluation study, which I'll talk about more about the study designs in the next slide. But here these are two different scale studies, just to pick one of them for this modular approach. So in terms of the study designs, A and B1 studies are pre-post evaluations basically. And those are like single arm pre-post evaluation, where we just collect data at baseline, then introduce the intervention, and then collect the data at the end line. One is for the efficacy evaluation. The only difference in both of them is the sample target population basically. For both the studies, one target population would be the beneficiaries of Fortify Health programs, another would be a separate sample selected by the researchers. So these two are very similar studies, pre-post evaluation without any control group. B2 study was an experimental design, where we have difference in differences design. It is a medium scale study. We are using this difference in differences design for this, just to see the impact of one of the Fortify Health programs. And then the last B3 study is a full scale randomized control trial, which basically also has two arms, and we can implement in one of the partnerships project. So this is the cluster randomized control trial, and in these studies the sample size would be different, but then B1, B2, and B3 are having the direct beneficiaries of Fortify Health. The beneficiaries, I'll talk about who are the beneficiaries for these studies, but then the size of these studies could be different, and because of the nature of these studies, cluster randomized control would be the ideal for like large scale impact evaluation. So B3 is also there in the model. So population for each study, for the study A, which is for the efficacy study, we are considering women of reproductive age group. These study participants might not be the direct beneficiaries of Fortify Health program. So basically, we have calculated the sample size for this small scale study. The A and B1 are very small scale studies basically, without control group. So we have calculated the small sample, easy to conduct these study. So we have a sample of 486 and 481 respectively. The only difference between A and B studies is that the prevalence we have taken is different. For women of reproductive age, at the baseline we are considering prevalence of anemia is like 55% prevalence of anemia for study, and for B1, 2, and 3 we are considering estimating the prevalence of anemia amongst the study population as 60%. Rest we are considering all the parameters very much similar. For the study A, the sample size which we have collected, we have considered that with the power of 80%, we can detect the change. Minimum detectable effect can be detected as 10%. If the prevalence is 55 at the baseline, we expect that it would reduce to 45% among the study population. And we have kept it consistent across 4 studies. The minimum detectable effect is 10%. And then 20% dropout rate is also considered for all 4 studies. So the sample is 486. Just because of prevalence, we can see the slight difference in the study A and B, despite being very similar in the nature. The study A is 486 and study B1 is 481. It is just because of the prevalence which we have considered, which is different. B1 and 2 and 3 are studies which we are planning to conduct among these children 10 to 15 years of age. And other parameters like dropout ratio and minimum detectable effect or power is kept constant here. The only change in the B1, B2, and B3 is B1 has single arm, B2 study has double arm. The study so the sample size almost doubled, and the study B3 is a double arm full scale randomized control trial where we are also considering uh, intra-cluster correlation. That's why the sample and also the sample is very high because of the nature of the study. So basically, this would give us an understanding that from the data collection perspective also which study is feasible and all. So this is the sample which we have calculated for this year. We can go to the next slide. Then the common elements in all four studies, when we talk, there are a lot of elements which are common and which makes it easy for us to create this modular design basically. First of all, the intervention would be common across four studies. It is the provision of fortified wheat flour, whether for women of reproductive age group, it could be the provision of fortified data in that daily diet. And for school children, we can introduce the fortified data in midday meal program. So this is the common intervention. Slightly the slight differences can be seen, but then the overall things are like very much common. Ethical consideration also, we would be going to the IRB approvals. All the study or four studies would be only implemented when these are approved by IRB authorities. So this process would be followed for all four studies, and the informed consent can be obtained from the study participants. And in the case of minors, we can have assent from the parent from the participants, and we can also obtain parental consent from the parents for the minors. So these ethical consideration, ethical criteria are also very much similar for all four studies. And the inclusion criteria, basically we want to have all those participants in the study population who are consuming fortified wheat flour atta regularly in their diet. So those should be included. In the exclusion criteria, participants who are already consuming some sort of iron supplementations, or are severely anemic, or are having any sort of conditions which are affecting the iron absorption, such as thalassemia, etc., and are or undergoing any transfusions. So in any of the studies, if these conditions are there, then participants should be excluded from the study. Data collection is also very much similar, the timeline and all. Since, as Prashad mentioned, that this is adaptive in nature, the document can be like changed at any moment. It should be adaptive. So data collection might change if the study timelines goes beyond 6 months or 1 year. We can consider having a midline, but as of now in the protocol, we have considered that at least one baseline and endline data collection on the biomarkers, indicators, and demographics and socioeconomics we can collect. So these are common elements which we have in our all four studies we have identified. And then the key indicators which we want to measure in our all four studies are like outlined here. That iron levels, the key biomarker indicators which we are considering here, serum, ferritin, and transferrin, we are considering them for all four studies because these are primary outcomes which we want to see, which we are interested in. So all four studies, whether it is a small scale or a large scale, we want to have all those for all those four studies. These indicators should be there. Also, the socio-economic and food consumption and dietary diversity indicators should also be there for all four studies, just to consider them in the how does that socio-economic status or like these subgroups affect the outcome. Basically, the knowledge of fortification, it is associated with the outcomes, but then it is not feasible for small scale studies. So we have considered them for two of the experimental designs which are a sort of a large scale studies. B2 and B3 are like including this knowledge on fortification indicators also. Some other biological indicators also we are including, that is cognitive and comprehension measures. Those are also excluded from study A. So these are indicators we are primarily considering for the measurement of these studies. Yep. Then the last part of the protocol, which is the data analysis plan for the group 1 and group 2. Group 1 is basically the pre-post phase studies, which I had mentioned. the previous slides, that A and B1 are pre-post designs with a single arm on the treatment group. So there we want to have the data analysis, descriptive statistics, paired comparisons, subgroup analysis and regression to see the distribution of distribution and the central tendencies of our data, and then within the groups, subgroups, how does this vary? The outcomes vary, and like how does this dependent variable is affected from independent variables. So in the group two, since these are like in nature, we are like considering them. We have control and treatment groups. So at the baseline, those should be very similar. And if there are any other factors which are affecting them, for that we want to consider balance table at baseline between the treatment and control group. Again, mixed effect for the random or like blindly the independent variable, or the random variables which are affecting or build the model, the relationship between these variables. We are considering them the difference in differences estimate to see the change in the outcomes, and to see over the period, like to control the time covariant, and then to see the change at the end of the study, and to understand that how much of this change can be attributed to the intervention itself, and you can see the compounding factors. So we are considering these different analysis for these two different groups of studies. So these things are included: study designs, sample and data collection or analysis plan, and all are included in the protocol. The protocol is created, but then it is in work in progress, because to complete the cycle of this protocol, we are working on budget planning for each study. Study A to study D3, all studies, budget planning for those studies, timelines, detailed Gantt chart. We have created a few for one of the studies, and we are planning to have an implementation plan for these studies. So it is a complete matrix from which we can compare these studies and pick one of the study which is feasible as per our urgency or availability of resources, etc. So these things also would be included into the protocol, and then as per our need and urgency and as per our feasibility, we can pick one of these studies and implement in our programs. That's all on the studies. Any questions?
Thanks, Ali. Yeah, the floor is open for the questions, but just opening the floor, I just wanted to conclude that the modular approach that we have taken is in the face of the that there are some uncertainties in the real world in terms of the funding availability, in terms of the timelines, and when we have to implement some evaluations, it takes a longer time for us to design the study, to take the necessary approvals, and then to go ahead with the implementation. And that somehow kind of competes with the priorities of the program implementation as well. So this approach kind of helps us to be prepared, have a more comprehensive approach, and be prepared to the complexities of the program evaluations that exist, and to kind of go ahead with very swifter and with a less time to start the implementation process. So yeah, so that is how we decided to kind of have a comprehensive approach, to think from all the different angles and not just think from just one kind of mindset that we have to evaluate and this is the program and this is the evaluation that we need to do. But this kind of approach can actually cater to a different programs that come up in the near future, even under partnerships in the government partnership. So the partnership teams, they work with a different government stakeholders and different quasi-governmental organizations. So there are multiple such opportunities for evaluation with different partners. So this kind of approach helps us to really tweak the evaluation design as soon as possible, and then start the implementation. Yeah, so I'll stop there, and I'll see if anyone has questions. Please feel free to unmute yourself and you can ask them.